institutions. It's Friday, January 17th. And it's 11 o'clock, or a little bit thereafter. We're now shifting gears and talking with the corrections. And we're going to be spending the rest of the morning talking about our medication for opioid use disorder, which used to be MAT, medically assisted treatment. Is somebody trying to come in?
That's me.
That's you, Commissioner? Somebody.
No, he's gonna share this slide.
Okay, so we have a whole crew of folks here from DOC, some folks we've seen before, some folks we haven't. It would be really nice to go around the room and identify yourself. So we know where you're from, who you represent within DOC. So I'm gonna start with the commissioner. We do know you, but.
I was really trying not to be on the record, but this is fine. My name is Nick Dillon, the Commissioner of Corrections for the state of Vermont.
Haley Summer, Director of Communications for DOC.
Isaac Dino, Policy Director.
Travis Denton, the Facilities Division Director.
Kristen Calvert, Deputy Commissioner of Corrections.
Eva Teva, I'm the Executive Director of Health and Wellness for the department.
I'm Dr. Jim Yoliger. I'm the Regional Medical Director for WellPath, a contractor with the state.
And then we also have some other folks here who are not connected with DOC. If you can introduce yourself, that would be great. Tom?
Sure, I'm Tom Abdelmar, the Legislative Coordinator for the Vermont State Employees Association.
Good morning, my name is Emma Regan. I work for the Nebraska.
I'm Peter Diori. I work for Beach Digger.
Okay, great, thank you. So we have within our correctional facility a program to help folks who are, there's addiction with substance use disorder. And this has been in place for a number of years. And next week, we're going to have a walkthrough of our law that allows MAT. I'm going to go back to MAT. I know the name has changed to MOUD, but we put a MAT program within our correctional facilities in place in law about 2018. It came out of this committee. We did a lot of work on it with DOC as well as the Department of Health. And the main thing that we really worked on was to make sure that the program that we established in DOC for our offenders who are there, residents, was the same as what you would find in the community. We didn't want it any less than what is available out in the community to folks who are struggling with substance use addiction. We didn't want it any more than what was out in the community. And that was our goal. That's what the law attempts to do. And the other piece of providing medically assisted treatment within our correctional facilities is we're seeing a substantial number of folks coming into our system with addiction. And it's not alcohol, it's a lot of different substances out there. And those folks are going to be coming back into the community. And if we can help them in their recovery, and they can begin doing that in corrections, when they re-enter into the community, hopefully they can continue that treatment when they're out in the community, which then helps the community be safer. It won't put as much pressure on our law enforcement entities back home. And also the person might be able to really thrive and not keep circling back into the Department of Corrections. Also, if a person is incarcerated, goes through detox, and there's no treatment, and they're there for a year or two, when they re-enter the community, those first 7 to 10 days are so volatile in that they will seek wherever they can to use. And that's when you start seeing public safety issues in your community. That's when you start seeing overdoses. That is the most critical time when someone is re-entering from an incarcerated setting, when they will overdose. So we were trying to address a lot of layers here to help people be successful when they re-enter and to help provide more public safety to our communities when folks re-enter. So that was the thinking of why we put it in place. The way that it is instituted within our facilities is through our medical contract with WellPath. And we have WellPath here as well. So that's the context I wanted to lay out for the committee to help understand. I hope I didn't take away some of your thunder. I hope it helped. I don't know if it did. But if both of you could again identify yourself for the record, would be helpful. And we do have a document on our web page as well. So we have some paper copies here.
Sure, sorry. Just want to say, I think we're quickly just going to walk through our kind of entire health system for members. I know, Phil, we were going to schedule a deeper dive on MOUD, I think maybe for the week after next. But this, we're going to touch on that here.
Yeah.
We'll, 1115 waiver, all the other pieces, but I'll let our directors here introduce themselves and we'll dive into that. Thank you.
Thanks. So again, I'm Aviva Teva. I'm the Executive Director of Health and Wellness for DOC.
Yeah, and Dr. Jim Uliger, I'm the State Medical Director for WellPath, the contract for DOC.
So we'll kind of go through this together. We work very closely together, emailing multiple times a day. So I think it'll be helpful to be here together. So I think that some of this was described by the commissioner a couple days ago, but the DOC has a strategic plan in place that's guiding our work. And health and wellness is one of 4 pillars. So it's really a big focus of what we're doing across the department, and having it spelled out in the strategic plan kind of allows us to connect everything we do, whether or not it's directly tied to health and wellness, to the health and wellness specific work that we're doing. So we did want to start with a really high level kind of overview of the health system, and in particular, the contract that we have with WellPath. So this is a 3-year contract. It started in July of 2023. So we're about halfway into it. The way the contract is set up, the cost is based on a per member per month calculation, which reflects all of the expenses of the healthcare services that we provide people who are in custody. It's based on a set population that is consistent, so we pay the same amount every month. And over the 3 years, that cost increases to account for increases in the expenses of the healthcare services. I think when I turn it over to Dr. Uliger, he'll be able to describe in more detail the health services themselves. But in terms of the contract, the National Commission on Correctional Health Care is what we use as the minimum standards for the care that is required in the contract. But we really aim to provide a community level of care. So that's the philosophy and the orientation of really the whole contract and what WellPath is committed to in that contract. We also partner with other Vermont agencies, the Health Department, DEVA, and AHS, for example. Again, Dr. Uliger will speak to the health services themselves, but they are comprehensive. So that includes clinic, kind of urgent care type services, infirmary level care, mental health, dental, on-site and off-site specialty, and really a full suite of health services. Moving on. Thank you. Just to give you a sense of the scope of these services, the average daily population is around 1,300 people, but a lot more than that are served in the course of a month because people are transitioning in and out of the facility. So there's about 1,800 unique people being served every month. How that translates into some of the specific healthcare services that WellPath provides. Every month, there are between 300 and 400 initial healthcare screenings conducted by the WellPath staff. That's 100 or 200 initial health assessments, over 3,000 sick calls per month. So that's the mechanism by which someone communicates with the medical staff that they need to see somebody for a medical concern. There are over 1,000 provider interactions, which is a higher medical staff level of service, as well as over 100 specialty visits that occur every month, and over 6,500 prescriptions dispensed per month across the system.
So I think we're going to have a lot of questions here. Gina?
I'm just curious, does the 6,500 prescriptions dispensed include the,
MAT
yeah, are we using that? Okay.
or MOUD?
MOUD, that's what I was looking for, program. And then that averages out to like about 5 prescriptions per person per month.
That's about the average
Okay.
medications that people are on.
Kevin, and then Brian?
So I'm trying to understand the difference between the screenings and the assessments. What, you give just a little. The first two.
Oh, the screening is, when somebody comes into the facility, they meet with a nurse in the first several hours. Make sure you're safe. What current conditions do you have? They call the provider if you're on medications. Make sure you don't list your blood pressure medicine, your insulin, whatever. The assessment is a provider visit. That is a fuller assessment where.
Thank you.
Brian?
And I was curious about the average daily population. You've described it somewhat, but we've been hearing about how volatile the population is. Somebody's in for 6 hours only, somebody's there for a long time. Who gets swept up? Who gets counted? How are they counted?
So I think I guess I'm not entirely sure I understand the question, but
So the average daily population is just kind of a running tally of how many people we have on a daily basis. You see that there's 1,800 unique individuals. That's because there's folks that come in and turn right back around, or people are getting released. So the number that we have in our custody on a daily basis, about between 1,300 and 1,400 individuals right now. That fluctuates a fair bit, but it stays in that range. But we tried to look last year, and I don't have the number off the top of my head, but how many people touch our system in a year? And it's substantially higher than the Noble folks.
Yeah, it's like 6 or 8,000.
Yeah, compared to the like, daily average being 1,300 or 14.
One of the 18 are unique. Yeah. Okay.
Yeah.
Okay. Thanks.
And if I may piggyback on that, the one thing you're touching there is one of the unique challenges we have in Vermont, having a mixed system of detained and sentenced folks, which is unique among healthcare delivery systems, because we have in WellPath nationally, there's a jails division and a prison division, and we're in the prison division, but we touch both. And it's a challenge and one we're happy to meet, but it's a lot of people we touch.
Right.
Yes?
so we wanted to describe some of the ways that we monitor these health services. There is very robust interaction between the DOC Health Services staff and WellPath staff. There's constant reporting and tracking through dozens of different health metrics, dozens of different reports that WellPath is required to provide us on a very regular basis. So we receive a lot of data about the services that are being provided and the health of the people in custody. We have quarterly quality control meetings that we really focus both at a facility level and system-wide on areas that we need to improve, concerns, emerging issues, challenges, and the like. So those are with both facility level staff, and Dr. Ulicker could speak more to the structure of the staffing, but there is leadership, medical leadership at each site, as well as a regional office. So we're kind of working at both levels all the time. We have weekly contract management meetings with regional office leadership, and we also have a thorough process for reviewing anytime somebody dies when they're in custody. So these are just some examples. Happy to answer any questions or share more, but there is a lot of engagement and interaction between DOC and WellPath. We are working together very closely on a day-to-day basis, and the WellPath staff are working alongside DO staff within facilities.
So when you say review meetings with DOC Director of Nursing and Director of Mental Health from regional office, what do you mean from regional office?
Sure. So the regional office is where Dr. Ulicker is based, and there are other.
So is that in Waterbury? Is that a central office of DOC, but you're calling that the regional office?
For WellPath.
It's the equivalent.
Okay.
And so within DOC central office, we have a director of nursing and a director of mental health who have clinical backgrounds. And on a weekly basis, they are meeting with Dr. Ulicker and other clinical staff in the Waterbury office for WellPath. And they review individual cases, again, concerns on a weekly basis.
So that's not many people look forward to their meeting with their regulator. I think it's a great meeting on Friday afternoons. We're gonna have it at 3:30 this afternoon. And we look at data and we look at people. I love doing both. And who are we concerned about? Who do we need to move? Gosh, we don't have enough room in our infirmary at this, who could we move around? They asked questions of us. I heard so-and-so isn't doing well. Oh gosh, I didn't hear that. Let's hear about it. So that's a really great meeting where we kind of get into the weeds with the DOC Health and Wellness staff. Love that.
Are you finding that our facilities are limiting in some ways of providing appropriate healthcare?
Absolutely. And there's two primary concerns I would have there. One is around some of MOUD is a great example because we have case managers, MOUD case managers that are in the screening room that are shared the same. We don't have space for them for all the services that we need to require private space to have therapy for those things. So that's one. The second, and kind of a bit of an urgent piece, is that our population, much like the population on the outside, is getting sicker and more complex, both in a physiologic and a mental health capacity. And one of the things we're really running out of is room in our infirmaries. In the Southern State facility where our biggest infirmary is, it has 8 or 9 beds, depending on how we count them. 3 of those beds are full of people who are just don't have any place else to go. They're kind of a skilled nursing. There's somebody be in a nursing facility on the outside. Those infirmary beds are meant to be, you're out of the hospital, you need IV antibiotics. So obviously we're going to take care of those guys, in this case, they're guys, to make sure they're safe. But and I will say our nursing director on the DOC partner side has been doing a great job. This is Brenda, of finding landing places for those people. But in 5 years, I imagine sooner, we're not going to have, we're going to be up to the gills in people who need both long-term and acute care. And we're already troubleshooting on a regular basis.
What age group are you seeing that? Is it your elderly folks or could it be a 50, 40-year-old?
Yeah, so most of the folks that we interface with live, fair to say, a hard life. And so, yeah, it is elderly folks, but not what you would think. Somebody in the community who might not qualify as. So yeah, 50 or 60 for some of these folks who've lived the hard life. They're running into age-related issues prematurely, I would say. So it's a mix of both, but there's that aspect.
Okay.
So the next thing that
We have a question.
Sorry. So you're saying seems like that's a crisis.
Yeah,
It's either happening now or
it's emerging.
It's emerging.
So I'm watching the curve, right? And we're handling it. We handle it regularly. But pretty soon we're just not gonna have space to handle it. So if you have 10 people who need infirmary care and 9 beds, what do you do?
Well, that's what I was gonna ask you.
Yeah, yeah, no.
It's gonna end up here.
So it's important, and this is physical infrastructure. This is nothing that, this is a long-term issue. So what are we doing? So there's 3 infirmary beds at Northern, our facility in Newport. Yeah,
Northern.
yeah, at Newport.
This is new to the committee in terms northern, southwest.
Yeah, thank you for yes. Yeah.
So if you could say the town would be.
Yeah, our Newport facility has 3 infirmary beds.
For 400 people.
Right. Well, so most of our sickest patients gravitate towards the southern facility in Springfield. Thank you. That Northern, so we're using those beds at Northern. The problem is the structure there. It's a bit of a fishbowl. So there's 3 beds behind a piece of glass, and if you have to live there for any period of time, even for corrections, you might be the only person in there. It's very isolating. There's no room to walk. At Southern, at Springfield, it's at least a bigger facility. It's maybe 3 or 4 times the size of this room with individual bays. People get up, they have their meal there. So how we can use that facility at Northern is a little, but we use it, so we flex there. We move the least sickest people to places where they can be watched. One of the things in corrections is a status called sheltered housing. So if you're in the infirmary, it's because you're sick. The nurse needs to check on you every 8 hours, those kind of things. Sometimes we put you physically in the infirmary because you have some piece of equipment. Maybe you're not that sick, but you're not safe in the general population. You had surgery and you have a drain. So we don't want, it might not be safe out in the, so those people, well, gosh, where else can we do sheltered housing that's not the infirmary? And we get creative, but it's hard because, sometimes, do you put somebody in a segregation area to keep them safe? But segregation's for punishment. We don't punish these people. They just need to keep them safe. That's not an okay thing. So we get creative, but we're running into an issue.
One last point, I won't drag it on, and these new beds cost.
They all cost.
No, that's not my.
Well, when you say a cost per inmate per year, all of that goes into that dollar. So it's not carved out. I suppose you could carve it out, but it would be more work on DOC's.
Well, can I ask?
My question was more like, what does a new bed cost for us to build?
Yeah, so this is an operations cost. This is, we don't charge more or get more when somebody goes into that. That's just what we take care of them. So you're talking about a physical infrastructure, and that's really on the DOC
That's the question
side.
for DGS.
Ultimately, we don't have the space. So if we want new beds online, that means new buildings.
Okay.
Fortunately, in Springfield, there is room to build new buildings, but they're not cheap. I think if you did a 1-for-1 comparison, just kind of back of the napkin math, if you did a 1-to-1 comparison for a general population bed versus an infirmary bed, certainly the infirmary bed's going to be more expensive. But I don't think we're talking about, and we're not doing this because infirmary beds are too expensive. We're not doing it because we haven't done infrastructural improvements really since Springfield came online. And one other just kind of contextual point here is when Springfield was built, and the chair can tell you well about this, it was designed to anticipate the growing need of infirmary space. That's why it has that's why it has a larger infirmary, and yet it was subscribed pretty quickly, and now we're oversubscribed and have been for years.
It was different 25 years ago in terms of the population that we were incarcerating. And that in terms of the population we incarcerate now is higher needs, more mental health than what was coming into our system in the 90s. Springfield came online early 2000s, 2002, 2003, in that timeframe. The makeup of the correctional population now is much, much sicker. And the opioid addiction has really accelerated that.
It's absolutely true, because you see pathology in and I say this with the deepest respect to our inmates who are our patients who are experiencing these things. But I would often love to have a medical student with me who's not going to see some of this pathology elsewhere, because people who have experienced OUD and may be experiencing homelessness come to us after months of that, and wow, we see some pretty sick people. So that's and Aviva's reminding me too, this, in addition to the physical infrastructure, there's a staffing component to this, both on the DOC side, which is not my wheelhouse, but on the medical side, which is we're fighting daily. And so that's an important piece too. Those beds are staffed at a higher level.
Thank you.
Anything else? Isaac?
Sure, just going to remind the committee, for those who were here last year, I think we did present some age data, but what we consider our geriatric population, which the national standard is actually 55 and older in the correctional environment, that population has increased 300% in the last 20 years in Vermont. And that actually tracks very closely national data as well. We can present more on that in the coming weeks. But I also wanted to pause really quickly. In your introductions, I was wondering as well if we could maybe hear who you are, like where you're coming from, like a little bit about your backgrounds just for the committee, because I don't think we quite touched on that. It's okay.
Yeah, so I came here to train at the University of Vermont Medical Center in family medicine. My wife and I were attracted to pediatricians, so we were attracted because we could be at the same hospital. I didn't have to be in one place and she in another, so we were at the same place. She worked in court diversion before she came here, which in Philadelphia, which was like in the 90s. It was like brand new at the time, and it kind of got me interested in the whole thing. I practiced primary care in the community in Heinsberg for 15 years or so before and as part of that was partially private practice. Then we're in University of Vermont. Within the University of Vermont, I got interested in structures of delivery care operations. So I was I had an administrative position for clinical operations. So not just, does the clinician make the right decision when you see them, but this is a very complex care to deliver. How does the machine deliver that care? And if we build the wrong machine, or if our needs change, we can't expect something different out of it. So I've been medical director for 6 months now or so. When I started, we have a long way to go. Like there's a lot of stuff we've got to do. And I was comfortable coming on as long as we were invested in fixing the machine. And this was to my well path. And they have been, thankfully, that's why I'm still here. But that's a big component of my interest. Between UVM and what I do now, I spent a year working in MOUD with a company that was using telehealth to reach rural areas, which was fascinating. I got my board certification in addiction medicine doing that. It was a lot of work in Vermont because we have such a good hub and spoke model. It was in rural Appalachia and whatnot. I enjoyed that, but wanted to come home. I never left the state, but I wanted to work here and take care of Vermonters. And this job opened up. For the first 5 months, I was our addiction specialist within the state. And we rewrote the MOUD standards, Annie Romenciano and Shannon Rogers and I, which we'll speak to if we have time. And then now I'm doing what I do.
So I grew up in Vermont and just returned also about 6 months ago to join the Vermont DOC. And previously my background was in mostly local government in Philadelphia and New York, and focused most of that time on reentry. So that's what brings me here, and I've learned a lot in the last 6 months, and I'm just
Continue learning.
privileged to be here. Yeah.
It's fun to learn together. We started roughly at the same time.
So why don't we continue with the cost controls?
Sure. So this was the last thing that we wanted to outline at this high level to sort of give background on how the contract is set up. So if WellPath spends less than the budget, then we get the money back as the state. So they're not incentivized in any way to spend less than the budget because they don't get those dollars. If they spend more than the budget, depending on how much, either they pay the difference, we do, or if it's above 6% over budget, we negotiate to figure that out. There are also performance incentives. So WellPath can earn up to 3% of the contract value by meeting different agreed upon metrics. So those are pretty, I think, standard kind of metrics of quality of healthcare. So timeliness, other metrics like that sort of reflect at the system level the services that WellPath is providing. DOC has the ability to withhold liquidated damages. So there's a detailed outline in the contract of, so basically if WellPath does not meet our expectations, we can charge WellPath for the time that it takes us to respond to whatever issue they're not meeting. At least since I've been here, we have not done that because they tend to work with us in very good faith to address whatever problems we're bringing up. And often, we're bringing up issues together and collaborating to solve them. But that is built in as a protection in the contract.
Right?
Mostly just for Isaac, I think. Can we see those performance metrics?
Absolutely.
For the bonus payment?
Absolutely. And lastly, WellPath is receiving a 10% administrative fee. So that's really the only direct profit that's built into the contract. Most of the dollars that we spend are line by line in the budget for the healthcare itself.
Was that 10% of, say, in year one, it was 33.8 million for the contract? Is that 10% included in that?
It's included. So it's actually included in the per member per month cost. Yeah.
Yeah, I think if we're just talking about the general contract now, I want to start off by, I've worked with the commissioner and staff on this over the last couple of years. So I'm not going to harp on it too much. I come in with a bias that I fundamentally do not believe that a private entity should provide healthcare to people in our custody. I want you both to feel very welcome here. And this is nothing about either of you. You're both very dedicated. You're doing your job, and I like what I've heard so far. But a private entity, we've had this in-house before and it's been mixed results in fairness. If I look at a private entity though, I worry about the transparency. I can't send a public records request right to WellPath. I worry about the accountability, especially when I see contracts changing every 3 years and maybe it's called something different, but it's a lot of the same people involved. And I worry about culture change, right? It's easier to change the culture in-house, I think, than it is a private contractor that's being renewed every 3 years. So I sort of come with that bias, I think. And, if I look at why are we doing this, right? Is it for recruitment and retention? I think the only thing I can come up with is it's less expensive than doing it in-house and paying a pension to state employees who would do it. And I understand right now, collaborating with a tertiary medical center would be difficult with their understaffing as well. But I think I need reassurance because, it's a rough Google search. WellPath, right? It's a rough Google search. In Vermont, when you look at the codeine Tylenol mix-up in 2003, we've had a couple instances here. But I'm really worried when I read an NPR a couple of weeks ago that there's, WellPath has filed for bankruptcy nationally, and they have to cut $550 million nationally. And, we're on the last year of the contract. I'm wondering how that's going to affect care. And I'm wondering if you could just assure me generally with any of the points that I made here.
Well, yeah,
I'm happy to try to assure you. So I can absolutely relate to your concerns. I personally find them very valid. I think those are really important questions to always be asking. In my experience working with WellPath, I have never perceived anything but kind of the intentions to provide the best quality care. Granted, a lot of challenges in doing that and a long way to go, like Dr. Uliger said. In terms of the bankruptcy, again, understandable that that's concerning and was for us as well. We've been assured by corporate leadership that our operations won't be impacted. And so far, they've been in close touch with us, the impact of it. The part of the company that provides our services has not been directly impacted in that they still are operating. It was kind of another part of the company that was affected directly. But we are in close touch with them about, for example, how the bankruptcy impacts their ability to pay vendors. One thing that we've learned that is assuring to us is that all of Vermont's vendors with WellPath will receive full payment for any debts that the company has. So elsewhere, that's not necessarily the case. Having filed for bankruptcy, some kind of outstanding balances can be renegotiated, but that does not apply to Vermont vendors. So all of the, for example, ambulance services that serve our facilities will receive full payment from WellPath. There's a little work to do to communicate that to everybody, which we're working on, but we're in close touch with WellPath about how that plays out.
I want to thank you. That was really helpful. I have the lovely, I don't write the checks. I don't write. So I practice medicine, which is what I just want to speak to my experience, and it's important. I'm speaking as a Vermonter and as a physician, and the importance of the people I take care of and not. So I have no skin in the game if we're public, private, I show up and I take care of our people. Healthcare has changed dramatically outside the walls, starting in around 2010, where it used to be very transactional. I showed up, I said, I've been coughing for 3 weeks. Like I said before, the quality of the care depended on the decision that clinician made at the time. They gave you the right medicine, the wrong medicine, whatever. I took it, I got better, I didn't. Well, somewhere around 2010, Blueprint got started. I don't know how much you guys know about Vermont Blueprint.
Mm-hmm.
Yeah, and Vermont had a blueprint, but every state has something like that. We got into meaningful use with the EHRs. Now, all of a sudden, we're expected not to have a good one-time transaction when somebody walks in the room. It's, doctor, how many people in your 2,000 patient panel have had colon cancer screening over age 50? How many have had breast cancer screening? Are you following the national guidelines? Who hasn't seen you in the last 6 months that should have? This changed dramatically. And so how we deliver care, and you ask anybody in primary care, so it was me, it is my wife right now who's running her, private practice in pediatrics. Very complicated. Inside our walls, the care we need to provide to take good care has gotten way more complex. and for many reasons, partially including the turnover of contractors, right, wrong, or indifferent, there has not been a progressive move to increase the quality of our care over the last 10 years by building that machine that I'm talking about. It should be easy for our clinicians to do the right thing. And with all and this is really important for me to say, because I hear you, you're kind, you're talking about the Google search that's rough, but you were kind to us. And I want to extend that to my providers. It takes a load of guts to sit alone in a brick building in the Northeast Kingdom as a physician assistant all by yourself there. And you got people coming in that are sick, and a lot of these people that we take care of, a lot of our patients are lovely to take care of, and some of them are not. And Corey, our physician assistant up at Northeast Kingdom, I have so much respect for what he does on a daily basis. So I will defend the care that he provides, and I want it to make it easy for him to do the right thing. And that's the machine that we build. And so this is getting to your question. When I came on, I asked for help from WellPath. I said, so I looked at the pay for performance things that Representative, I'm sort of needing that reading glasses, but not yet. I'm very, yes.
We'll have a seating chart up here.
Yeah, I appreciate it. But so I looked at those, and these are not okay. But it's not necessarily, they were the same than they were like for WellPath. I'm saying that qualitatively, like they weren't, maybe they were a little different, but they weren't. So I asked for help from corporate. I said, we need help. And you know what? They brought it. Like we have a whole change management team that's come in. We have a project manager. We have an expert. We are like, how are we taking care of blood pressure? How are we looking at our risk screens when they come in? Right now we're involved in how do we give medications to be compliant with the most recent legislation about giving people medication to fill that gap until they see the primary care provider when they leave. That all takes work, and I'm getting support from corporate in that. And I find that reassuring. I really couldn't ask for anything different. So I'm not waving the flag for WellPath. If I'm not doing this in however many years, I'll be doing something else to serve our community, I hope, but I've been getting response.
Thank you very much.
We have another question. Troy?
Just give me the other side of that coin. When have you been frustrated with WellPath since you're in, 6 months, right?
Yeah.
What needs to change? What needs to be fixed?
I've had frustrations that have been, a load of them have just been addressed. So when there's a request for something to change and kind of you do your doctor part and you're like, this looks good. I'm happy with this. This can go forward. You need the people that move that forward to move it forward. And there's been a couple times when that hasn't happened. And that's different now through a variety of, and I can't give all the details, but there've been a variety of changes that have, now it's happening.
So like administrative lag, is that how you would say?
Well, so the release medications is a great example. I batted that around with how can we do this safely? How can we be compliant with the law? How can we be make sure people get what they need and not what they don't? All those things. As a physician, and my job is sort of done.
Yeah.
And then somebody needs to plug it in. How do we actually do that work? How do the meds show up? How did that? And that was not happening in September and October. I was really upset. Guess what? We have those resources now, and it's happening. We're about to deploy it. We did the training. I did the last leg of training yesterday. We're going to deploy it Monday.
Right.
And that's a little over a month after those resources arrived. Now it's ready to play. And so that's when I've been frustrated when health services or the legislation is asking for something. I agree that that's a good thing. I kind of put some tweaks on it to make it medically appropriate. Let's go.
Yeah.
And when it doesn't, I don't like that.
One follow-up for my friends behind me. Is there any data being collected or surveyed on the patient satisfaction?
Yeah.
Okay.
Which is available on our website. I don't know if you wanted to answer that.
Yeah, we just completed, so a full patient satisfaction survey was done in 2023, and we just completed the last one in the fall. So we should be able to share the results soon, but across the board, the patient satisfaction improved since a year ago. So I'm taking that as a very good sign. It's still not where it should be. We again have lots of work to do, but hopefully moving in the right direction as reflected by people's experience with their healthcare.
Thank you.
Just everybody's struggling with like recruitment and retention, and honestly, providing medical care in the walls of a prison is a pretty tough gig for anybody. So hats off to anybody who does that. But with the contract and the allotted positions in that, how are we looking for vacancies at the moment? Are we reliant on traveling nurses? It's just hard to fill a staff.
Yeah, and so I'm in this seat, I'm occupying my own role, but I'm also trying to pull from the heads of like all my staff members who aren't here. So I met with our nursing director this morning, and Southern's our hardest sell. And my understanding is that we're going to be fully staffed as of next week, which is in the last several months, that's been very difficult. And she, as the regional nursing director, has been down there acting as the local nursing director. She's turned that place top to bottom. And we're in a very different place than we were 6 months ago. So she was, and I'm not advertising for WellPath, but she was a WellPath recruit that came from Michigan, worked firmly in their Michigan contract. A lot of experience running a 30,000 person system. You know, we have whatever it is, 1,400. So she was able to make the place run very differently, and we're going to be fully staffed. No, and I'm not trying to say, oh, our staffing problems are solved. No, we have big staffing problems, but we're hitting them. And with minimal of agency, and we use agency when we have to because care is most important.
Thank you.
So let's keep going.
Thank you.
That's fine.
No, that's my fault.
That's
Yeah,
fine. No, that's what we're here for.
So I think at this point, Dr. Uliger, if you could kind of walk through and take in screening in the process when someone arrives.
Oh,
as a
sure.
service you could bring.
Yeah, and I alluded to this a little bit. And I'm going to have to cheat with the actual hours because yes, okay, good, they're right in front of me. So when somebody begins, yes, I know, and I'm still learning. I'm a rookie. I'm a reading glasses rookie.
Some of us understand that. Never done that.
So somebody comes into booking within 4 hours, like we were talking about before, they see a nurse and are assessed for, you know, what's your blood pressure, what's your what medicines are you on, all those things. Also, are you well enough to come into the facility? Sometimes we have to send people right back out to the emergency room before we can take custody of them, or before the DOC can take custody of them.
So can I just ask a question there? When you're doing the initial, and you're at the admission or you're at the screening?
Facility admission is not, that's
It's
healthcare
what you just-
contact starts at receiving, yeah.
So in terms of a person being on medication that is coming in, they're on blood pressure, cholesterol, whatever, they give that information to you voluntarily, correct?
Yes.
So it's not they're not required per se. I mean, they're required, but it's up to the individual to provide whatever information they want.
It's true, and they also give us permission to reach out for verification to pharmacies and primary care
Right.
providers.
Or they could deny that.
They could. So denial is in my last year in corrections, that was something I had to get used to. We don't force people to accept medical care. I'm trying to, I was on the phone with the nurse yesterday. I'm trying to make sure the whole team has really kind and generous but clear words. I think you're making a bad decision by not sharing with us your and they're trying to stick it to us. It's not, I want your blood pressure to be well controlled. I want you to be okay, but we're not going to force you to do anything, right? And that really puts the locus of control in them. To your point, often, so we do screening. We screen for mental health. We screen for opiate use disorder right in that encounter right away. And a lot of these things are they're required, regulatory, like required. A lot of people will say no to all of it, especially for opiate use disorder, you know, in custody standing, you know, just around the corner. Have you used fentanyl in the last 24 hours? Oh, no, yeah. No, and then days later when they find we have all the things, hey, can I see somebody about my opiate use disorder? Yeah, so that's something we're trying to, then we're kind of going through the screening twice and we're trying to figure that out.
So I wanted to bring that out for the committee. Understand that when a person's coming in and being screened through booking, the information that is given to the staff or to the person doing the screening, it's voluntary on the part of the offender or inmate or person coming in. It's voluntary. And I just want folks to keep that in the back of their mind, because that there's a lot of ramifications from that. If you get into visitation with children, sometimes they'll say they don't have any children when they do. So I just want you to keep that in the back of your mind. The information that's given is voluntary on the part of the person that's being incarcerated. Well,
So going back real quick, just to the contract part, where it was talking about what this year's amount was for that per member per month, and it was 37.1 million. You said that, you know, obviously that they voluntarily submit to medication and certain treatment. For people that don't, you know, voluntarily join that, are they included in that per member per month? Well, yes, we're still providing healthcare, and they can agree or not agree to any sort of, but as a matter of fact, it's more work when somebody honestly declines something because of the documentation, and where somebody declines a certain medicine or declines, it's a lot of work to document all of
into, well, no, keep going. I've got another question, another question.
The contract cost is based on a set number of people that isn't exact, that doesn't change, whereas the actual population changes day to day. So it's not per person actually served, it's an average.
So in those screenings, and you talked about, you receive information about their primary, who they're hooked up with, primary care provider, who they're hooked up with a pharmacist. How many of them are hooked up with primary care, and how many of them are not?
Yeah, and you know, I do not know that number. I think it's an important, that's an important number to kind of have in our, and
What's the gut reaction to that?
oh, the gut, I don't know. Vermont is special. In another place, it would be 20%, 10%, 15%. Here it's a lot that
Primary,
have a primary care provider. Our people are coming in on medicine, right? They're coming in on medicine. So clearly, I don't know, 2/3, like, which is very high in the, and we have all sorts of types of people. I don't want to generalize about our population, but we have a population that lives a hard life, and not all of them see somebody. So I think there's more than would be at another place. Should I keep going through the process here?
no assessment.
Yeah, so assessment. So there's two things that happen, maybe three in the first, and ideally it all happen within the first 7 days, but they're supposed to have an assessment, which is they meet the provider. And there's really two things. That one of those assessments is what I would call it kind of a checkup. It's a primary care visit, like a preventive health. And the other is if you have chronic healthcare conditions, we do the first chronic healthcare visit, which we do quarterly for the rest of your stay. So that is a lot of work. One of the reasons why it's having detained folks and sentenced folks, that mixed population, doing that initial assessment is a lot of work. And then sometimes people leave a few hours later. And I'm not bemoaning that. Sometimes our excellent providers, I did all this work and then somebody left. Many times we can get people hooked up on MOUD right then and there, which is, when that works out, it's really nice. So we have the initial health assessment, so that preventive healthcare, and then that chronic healthcare, and those happen within 7 days. The mental health and substance use assessment, those are as determined by appropriate screening assessment. So the one of the things I'm privileged to have, one of the resources that is better when you're a primary care provider in this kind of facility compared to the community is that I have psychiatrists. I have access to psychiatrists, and I have access to behavioral health folks, which I did not have when I was practicing in the community very easily. So the mental health piece, when people screen positive for depression, anxiety, whatever it may be, they're assessed by mental health. That kind of is a different stream than the one so I can't speak with a lot of in detail about that particular process, but it happens. They see a behavioral health specialist, and if they need to, they see a psychiatrist or a psychiatric nurse practitioner. And the substance use assessment is within what we call the somatic, the body part that happens in medical, not the psych part of it. But they might see a one of our, we call them MAC case managers. They're really, to your point, an MAUD case manager. That case manager, much like when you're admitted in the community to an opiate treatment program, we verify. So before we start buprenorphine, we're supposed to, do you really have an opiate use disorder? Have you been treated before? What is your use pattern? Like all those things. That's the assessment they would get if they need it. Often those people declare themselves pretty clearly because they go into withdrawal in, 24 to 72 hours or thereabouts in the facility. So we know who they are. It comes up pretty quick. One of the things we are not doing now that I would like to do very much, it's a Department of Justice guideline that people are treated when you're in withdrawal. Traditionally, we've treated people with, here's some nausea medicine, some Tylenol, some Gatorade. We'll get you in to see the MAP provider when we can. We need to give you buprenorphine. When you're in full-on withdrawal, the right thing to do is, whether it's buprenorphine or methadone, we can't offer methadone because we're not an opiate treatment provider. But unless there's a reason not to, we need to treat, and the DEA allows us to treat before you have the full assessment, which is required because we don't want to give buprenorphine to people who don't have opiate use disorder, right? So we're required by the DEA to do a proper assessment. But 72 hours in advance of that assessment, you can say, this person's withdrawal, you give them buprenorphine. We are not doing that. It's going to be a little bit of work to get people to do that because it's.
What's stopping you from doing that? Is it just within the contract and regulatory, or is it legislative?
You know what? It's workflow and provider confidence, and the fact that this sometimes happens in the middle of the night, and how do I get all of our providers? You can imagine I have a mix of provider confidence in treating opiate use disorder. I'm working on that. I'm trying to bring them all up to speed. There was, and if and when it's appropriate, we could talk about the new guidelines that just went into effect that were really bringing what was our nascent opiate use disorder treatment now up to speed, because it was revolutionary when it started and then it didn't change that much. So it was time to give it a facelift. So through that, really through the policy, we're teaching to all the providers through the policy. And the WELP, for example, when somebody comes in opiate use disorder, we often, here's full dose is 16 milligrams. If you've been on fentanyl on the street, you need 16 milligrams and probably 24, but 16 will do you for beginning. People are getting 2 milligrams, then a week later, you'll have 4, and then a week later. And that is appropriate in different settings, depending. But if you're using intravenous fentanyl, let's get you up to 16. That made people nervous because you get nervous when it's not your specialty. Trying to give people confidence. We changed the induction protocol for people within withdrawal. You get up to 16 within 48 hours. So getting our providers confidence is one of the things. Changing attitudes all across the board, from providers to medical to our corrections officers. And I'm fortunate that, I have many of my colleagues from DOC, that it's great to have leadership that embraces a treatment. But that doesn't always filter down to the all of the front line, right? And it does over time, but Travis, you would see, we have some people that don't see eye to eye with a therapeutic mindset. So that you asked about the barriers, that's what it is. Dental, within 30 days of admission. So if you want to know the biggest barrier to that, it's a dentist. And that's been one of our biggest staffing problems. We do have one at Southern who's gotten great reviews. That he's the person that treats me like a human being more than anybody else I've interfaced with. And so I got to give him a lot of credit. We have a new one at Northern. We have a new one at Newport. We don't have room, my understanding is, at Marble Valley, but we transport those people to Southern. That some people don't want to take the trip, and that's part of it. We do have one at the women's facility, Chittenden, in South Burlington. There's a dentist there now. At the top of my head, I don't know where we stand at Northwest.
Well, we recently adjusted the staffing matrix to try to make it easier to hire and keep dentists. I know that, so.
Yeah, so forgive me, I don't know our status at in St. Albans. And then after that, people see us quarterly if they have any chronic medical conditions. I'm actually trying, and they should see us quarterly. Sometimes it's 100 days or 120 days. That's not okay. There's nothing contractual or regulatory that has to be quarterly. And so I'm trying to change the culture where, you know what, if somebody just has heartburn, see them every 6 months so we can get our OUD people who might not be doing well, or our people with poorly controlled diabetes, we should see them quarterly. So we're doing some, sadly, there's not a lot of people who just have heartburn, right? Most of the people who have a chronic disease have a lot going. One of the things we're not meeting, and I've made it my kind of goal in 2025, we're not meeting the hypertension for the paper performance. That's largely due to reluctance to escalate therapy. And I don't know where that's coming from, but I'm doing education with all our providers. Let's escalate therapy. Let's see those people every 3 months, and then we can see them every 6 months or more. So I'm trying to realign that, and that's what we do in the community. We might not see you for a year. You know, the thing with community standards is interesting. We want to do the community standard, but also the prevalence of disease is not the same as it is in the general population, right? So we're kind of, it's probably not appropriate to see people with chronic disease annually in most situations. But for some people, 6 months might be fine, so we can see the sicker people more often.
What percentage of the sort of incarcerated population would you say would be designated SMI, serious mental illness?
Yeah. I don't know the number. It's not a small number, but
I don't know it offhand, but I think it's about 50 or
15%, isn't it?
SFI is a pretty specific designation.
Yeah.
Which is different than
I
SMI.
looked at it yesterday.
Okay, yeah, I think I'm gonna mix up a bit.
SFI is 4%, but that's not.
It's severely functionally impaired. It's a special designation.
Could I ask you though, like, so, they're having a rough time. I met with workers up at the Vermont Psychiatric Hospital there, and I know some of the population you get would be pretty severe. So if somebody's in like an acute mental health state, do you actually go through the process of petitioning for involuntary medication in some cases?
Yeah. They will go to the state hospital if they're of that acuity. They will go to the state hospital, and once they have leveled off, they will come back to DOC. So it's there to help them level off.
But you wouldn't provide it in the prison, you would bring them to the psychiatric hospital, would
Depending
they
if
provide
they
it?
meet the acuity level. And then when they're stabilized and have leveled off and taken care of that, and they're no longer at that acuity level, they will come back to DOC.
Yeah, that's all correct. Our director of psychiatry, who I work closely with, would know the nuance. I will tell you the number of time, I don't think, I'm quoting her and I may be misquoting her, but giving medications against somebody's will for psychiatric disease, there's an extraordinarily high bar for that. And I don't think we've actually used that in the facility. We do petition for involuntary hospitalization. There's also a very high bar for that also. But if somebody needs involuntary treatment, typically that's the route it's taken.
You have to go through the same system of involuntary meds as on the community level as well, because there was a time there that the commissioner at the time wanted to relax that drastically, and the legislature did not agree with that. Little history. So let's keep going.
Oh yeah, we're so MOUD. So I could be I'll try and be brief about this. I do see that we're over time. So like I said, and I was not around for this. It sounds like, Chair, you were.
Yeah.
We're getting OUD in our facilities, mountain of work. A year ago when I came in, it had not changed a lot when it started. So we have a 15 or 16 page policy that's new. And what that focuses on, it's on a few things. It's number one, diagnosis, because we need to be treating people with OUD and we need to treat it well. The problem is when you talk to people who might be in the facility, they're like, well, this person, they shouldn't be on it, or this and that. There are some people, we maybe have the right number of people on it, but it's not always the right people, if that makes sense. So if you come with a cocaine use disorder, you should not be on OUD, MOUD rather. But people are seeking a little substitution for their, if you're addicted to X, you're addicted to Y, you could get some comfort from Y, but that's not the FDA indications. It's a big focus on diagnosis. It's a focus on, this was, for those of you who may not Annie Romanciano was the, how would you describe Annie? She was the champion. She worked on the DOC side of health and wellness and was the champion of getting this done in the facilities. Annie, when we were doing this, she no longer works for DOC, but at the time she was very much into getting the consent process. It was very contractual. If you do this, then we'll do that. And that's not a therapeutic, that's an enforcement. So it was a rights and responsibilities. Same idea, right? You have to be a good steward of your medicine. We said that in, fourth grade reading level, whatever, but it's a different thing that this is for you. This is for you to get better. It's not you're going to get in trouble. Third thing is how he handled people who are caught diverting or doing other things with their medicine they're not supposed to. And if I could put it in layman's terms, people with use disorders make bad choices, and you don't get over that overnight. Part of the diagnostic criteria is that you've made bad choices around your opiates. That's right in the diagnosis. So it's not like all of a sudden we're going to give you this med and then now you're going to make great choices. So we have to account for that. There needs to be a therapeutic response to poor choices that are made and not a punitive one. At the same time, if you're the hookup for your unit and you have all the diverted medicine and you're the one who's giving out exchange for shoes or for money or for, that's not okay. That needs not a therapeutic response. That needs and it was really bringing up that response in line with the the American Society of Addiction Medicine 2020 guidelines. So we were getting our response. So the first response is you meet a person as a provider, not as a cop, and you ask them what's going on. So one of my first days that I was on site, people said, well, this person's diverting, and we went through all the specifics. So this provider was like, what should we do? I was like, this person needs a higher dose. Because in the past, if somebody was caught diverting, we warned them, then we cut their dose, then we took them off. So what we're doing is making it harder and harder for them to make a good choice. So for that person, and this is not always, sometimes we do take people off still, and only when it's the right thing to do. But for this person, we increased their dose, and the person was floored. I did better. I did great better because he's on the right dose. There's another thing when the whole piece was put into play, fentanyl hadn't made its big debut yet. So there was this, not that this was in the legislation, but there was this concept that the ceiling was 16 milligrams. You never go above 16 milligrams. Well, guess what? By SAMHSA and by other guidelines, we need to go to 24 milligrams sometimes. And occasionally we need to go above that. And that was, talk about a culture change, getting people to understand that we can go to higher doses. That was challenging, but that's what we're doing.
Excellent.
Or I was just gonna say, and DOC's coming back in a week or so to give a much more detailed on this particular thing, so.
Yeah, and we could be more, and we're working together on how we're gonna kind of normalize some of the distribution of medications and make it like any other med. Right now, it's in a different med line, so guess what? You have no privacy. If you're in that med line, you have opiate use disorder, right? And everybody knows it. So I love it that we have people who are willing to engage in that change.
Correct.
You mentioned that you're not able to prescribe methadone because you're not an ODD treatment center. Is that a path that we should be looking at?
Yeah, no, that's a big, yeah. So
Big issue.
we collaborate with our community providers.
No.
And we do give, if somebody needs methadone, we make sure they get it.
But would it be more streamlined?
If we became an OTP?
Yeah.
Yeah, that's a big question and I don't have all the answers.
No, for correctional facility, there's such a high bar to become one. I don't know if a correctional facility is even allowed, because we looked at that when we did the MAT. Why can we not be a hub? And there were a lot of regulations around.
It's very highly regulated. There is an NCCHC standard, which is the National Coalition for Correctional Healthcare or something like that. There is an NCCH standard for OTPs within facilities. So I believe we can do it.
We have a vehicle.
Buprenorphine is a lot safer than methadone in a diverted population.
Yeah.
So one of the things that keeps me up at night is people divert our liquid methadone, which I don't know how they do it. They're supposed, they take the dose, they have a cracker, they say they're ABCs and they're gone. You're supposed to not be, but they divert it. They find a way. And the last thing I want is to find out somebody overdosed on diverted methadone.
Right.
So if people need methadone, they should get it. But if they don't need methadone, it might be nice if we stuck with people. And that's been my standpoint.
Thank you.
Yeah.
I can talk about the 1115 waiver. Medicaid reentry projects. So at the federal level, people who are incarcerated are essentially excluded from Medicaid eligibility, but that is in the process of changing. Vermont is one of a handful of states, a growing number of states that has special approval for people to be eligible for Medicaid while they're incarcerated. And so we, starting in 2026, will be providing Medicaid services to people who are sentenced 90 days before release. So what that will do is allow us to provide additional case management and care coordination pre and post release, as well as kind of generally over time build out the services that we can provide people to improve health outcomes long term.
So in terms of the appropriations budget adjustment, there is some money being requested. Because in order to implement this, both, I'm assuming both DOC and at Department of Vermont Health Access, the electronic system needs to be changed or updated in order to allow this to kick in. So we're gonna hear that testimony next Wednesday, hopefully, and Kristen's gonna hook up with DOC here. We'll hook up with Phil to schedule this with both DOC and hopefully DEVA. Because the IT system has to incorporate this program. So that's the delay in setting this program up. And we need to weigh in on that as a policy committee for DOC and make our recommendation to that appropriation request to our appropriations committee. That. This will be a big help also in combination with the legislation we put in place last year. When Ben came in and gave us the walkthrough of the reentry, the medication for reentry, this will be a big help to that because the folks can then kick into having health insurance prior to them being released from a facility. Be very helpful. It won't help the detainees, but it will help the sentence folks. Any questions on this whole presentation? Sean?
I don't have much of a question, and I know I'm new at this.
We all are.
But it appears to me that Dr. Eulinger and his team are providing not only adequate care, but care that would be equal to any of us getting here in Vermont. And I just applaud you for that. And it made me feel good just hearing how much you care about the people you're taking care of. Thank you for sharing that with us.
I appreciate it very much. And though we're on a journey to reach what you're talking about, we are not there. So I want to be clear. We have some stuff that we need to fix. And what I'm happiest about is that I have a team of people and investment. And again, I'm not advertising for WellPath, but I'm getting support from WellPath to put those changes in place. But I do care deeply about it. So I'm glad that you too.
Thank you.
Joe?
We'd heard other testimony regarding the lack of Wi-Fi in the facilities. Does that create challenges for you in fulfilling your mission?
Yes. It does. They're not things that, again, I'm speaking for my colleagues. So if I misspeak, I apologize. One of the things I believe the challenge is live Medline. What live Medline is when you go to a unit to pass meds, you want to record that all on the computer while you're doing it. And that's the standard of care. A lot of people have to take pen and paper. Yeah, I did this, I did that. And then you transpose it. That's a setup for error. So that's one I can't.
Thank you.
So it would be really helpful for changes that you see need to happen. Some of that is internal administrative regs, policies that, but if there's any legislation requirement, it would be really nice to hear about it.
Yes.
Know about it so we can start working on it. I would also recommend to GOC, if you haven't been reached out, you probably have at this point, but our counterparts in the Senate Institutions Committee now has jurisdiction of corrections. This would be an important testimony to present to them. It'd be very important for that. So I know they're kind of overwhelmed right now. I'm just trying to understand some of the basics. But this later on would be very helpful to go there. Anything else? Great. Thank you so much for coming
Thanks very
in.
much.
We're gonna have you back, I'm sure, doing deeper dives here, going into more in depth on some of these. Thank you. And we'll go off of YouTube.